Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study MRCPI, and we are here with another OMR series, which is OSCE Made ready for all of you who are going to appear in your Feb MRCPI OSCE exams. So, if you have not subscribed the YouTube channel of Study Medic, subscribe now and click on the bell icon so that you can stay updated with the OMR series, which are specially designed for all the OSCE going candidates for Feb 2026 exams. Before starting the task, the message for all of you is that you must tell yourself that no matter how hard it is, how difficult these days when you are revising, preparing for your exam, but you are capable and you can do that. So, warm welcome once again at the YouTube channel of Study Medic and Study MRCPI. And this YouTube series is for all of you to make sure that you can understand that how the OSCE tasks are and how you have to answer the examiner in the exam. The task which we are going to discuss is a structured discussion in which I would be I would be candidate and I have examiner with me, Dr. Soumya, who needs no introduction, and she is mentor of the mentors and she will be as examiner in this task. Hello, Dr. Soumya.
Hi, Tazeen. Thank you so much for the kind introduction. So, yes, thank you. I'm sure you will make this task very easy for them. Sure. Thank you.
Thank you so much. So we shall start the task, and this is how you will get the candidate's instructions. There is no reading time in MRCPI exams. You just have to take few seconds to read the instructions and then you have to start. And meanwhile, the examiner will be asking you the questions in the structured discussions. So how you will start, let's see. Hello, I am Tazeen, one of the exam going candidates. I have read the instructions and I am ready for structured discussion.
Okay. Tazeen, can you summarize the case for me?
Yes, this is a case of 26-year-old pregnant woman who has presented to us with vaginal intraepithelial neoplasia type 3, and she is also a case of HIV and also a previous history of cervical intraepithelial neoplasia which was treated. So she is therefore a high risk patient with perspective of multifocal lower genital tract disease, with increased risk of persistence of the disease, progression of the disease, and also the recurrence of the disease, particularly due to her immunodeficiency status due to pregnancy as she is HIV positive. So additional information is needed in this case. We may need to perform examination and may need to run some of the investigations to manage this patient.
Okay. So, what additional history you would like to take for her?
So first of all, in the additional information, I would inquire from the patient regarding her symptoms that about the vulval pain, that what actually exactly is the site of the pain, since how long she is having this pain, and whether she is having any pruritus on vulval area, any bleeding or bleeding on touch, any ulceration if it is present, or any abnormal discharge. What is the duration of these symptoms which she is having, and whether there is any change if any vulval lesion is present, whether there is any change in the appearance of this vulval lesion, or any such lesion or any such it is present if anywhere at other site of the body. Then about her HIV status, that since how long she was diagnosed with HIV, what about her compliance with the antiretroviral therapy? When was the last viral load which was carried out, and CD4 count as well? Her obstetric history is very important to know, that whether if it is her first pregnancy, how the pregnancy has been so far. Also, it is planned pregnancy, whether she received any preconceptional care, keeping in the perspective of HIV positive. Also, her previous history that she was treated for cervical intraepithelial neoplasia as well. Any other medical concern apart from this, which needs optimization during pregnancy. Then her follow-up of cervical intraepithelial neoplasia, when was the last follow-up, what was the advice, and if any notes are available, like when it was treated, about the margins, whether they were positive, and how it was excised. That is very important. And with patient's permission, I would like to review the notes if they are available. Her general health, like her personal habits, smoking, alcohol, any drug abuse, which is very important. Her other any if she is having any other infection, and as she was previously treated with cervical disease, and now also HIV, and now she is having this vulval lesion. What about the mental health of the patient, with how she is feeling, how is support at home? And in this particular patient also, her sexual history is very important. I will ask sensitively how many sexual partners she is having, and whether she was treated for any sexually shared infections in the past, and what about the follow up. Also, examination is important in this patient. So I will perform the examination in this patient. First of all, general examination regarding her observations of blood pressure, pulse, temperature, as she is a known case of HIV. So general look of the patient, and her immunodeficiency state, how is the general look of the patient, whether she looks cachexia, or she has lost weight, or what about that. And then coming to the local examination, I will do the examination with her consent, in presence of chaperone, being very careful that if any lesion is there, first of all, inspection of the lesion, that what is the site of the lesion, how it looks like, any color changes in the lesion, if it is there. Then I would be very careful to touch the lesion if I have to palpate, as it can bleed on touch. So I need to be very careful in that. The invasive disease needs to be excluded. And also I have to perform the speculum examination, as well as this patient was treated for cervical disease. So I would like to have a look at the cervix as well. And if any other examination is suggested, I would like to perform that as well.
Okay. So, what are the differential diagnosis you would keep in mind considering the history of this patient?
So, as this patient is basically the diagnosis, biopsy has already been performed. So, this is vaginal intraepithelial neoplasia, and that is keeping in view her previous history of cervical pathology. So, this can be human papilloma virus related, which is the usual type. This can be condyloma acuminata. This can be squamous cell carcinoma, or this can be lichen sclerosis as well. And this can be any other vulval dysplasias as well, which can be the reason of this lesion in the vulva.
Okay, what additional investigations you would want at this stage?
All right. So, as the vulval biopsy has already been performed, if it is not there, so we may need to perform vulval biopsy, but it is already there. Then we have to perform HIV monitoring is very, very important in this patient. That what was the previous viral load, which was the recent one? What about the CD4 count? As we have to see the immunodeficiency state and the control of HIV in this patient. Also to review the cervical cytology and to review the notes. If colposcopic examination and notes are available, we have to review that. And also we have to apart from this, the baseline investigations would be there. If there is any suspicion that invasion of the disease is there, then we can go for imaging, but at the moment imaging is not needed, as the from until the suspicion of invasion is there.
Okay. Since she's 26 weeks pregnant, so she has got VIN 3 now. So, how you are going to plan her management?
The management of this patient would be by a multidisciplinary team involving oncologist, general gynecologist, specialized nurse, as well as infectionist as well. So first of all, the woman, she would be counseled about the diagnosis, that and what are the what can be the fetomaternal implications of this diagnosis, and also to reassure the woman that this is a pre-malignant condition and not a cancer. After this, first of all, as she is pregnant, and if the vulval lesion is static and it is not growing, and there is no evidence of invasion, conservative management is advisable in this case. if for the conservative management, first of all we have to advise her general lifestyle measures and personal hygiene, to keep the area clean, to use the emollients, and to keep the area dry, to avoid any irritation, also to use breathable undergarments as well, and cotton undergarments, so that it is not causing any irritation. If there is any lifestyle modification which needs optimization, that needs to be, like if smoking is there, that needs to be stopped. If she is overweight, we should advise healthy lifestyle to reduce weight gain. And if any medical concern is there, that needs to be optimized along with the multidisciplinary team. Then we should be careful about her symptoms, that if there is any progression of the disease, we can go for conservative management, and definitive treatment should be deferred until postpartum, if there are no severe symptoms. And however, in the postpartum period, we should go for excision of and we should go for biopsy. Electrosurgery can also be advised in this patient, and if the lesion is large, then extensive surgery may be needed in this case.
Okay, because she's HIV positive as well. So does that affect the management or how different it is for it?
HIV basically is affecting the immunodeficiency state of the woman. So this can be a multifocal disease in this woman. Then we might have problems with the recovery phase of the patient, being she is being immunodeficient. So the progression and persistence of the disease can be there. And also, if HIV is not, she is not using any retroviral therapy, and her immunodeficiency state is the same, then recurrence of the problem can also be there. So we have to make sure, along with the multidisciplinary team, that she is adherent to the antiretroviral therapy for the control of HIV, and we should coordinate with the infection control team as well as HIV team, and we should do the close postpartum surveillance in this woman.
Okay, will VIN3 affect the mode of delivery?
Vaginal intraepithelial neoplasia is not an indication of cesarean section, so it won't be affecting the mode of delivery until and unless there is a large lesion which can obstruct the birth canal, or it can be distorted. So in that case only, we may need to consider operative delivery or cesarean section. Otherwise, it is not an indication. However, we have to be very cautious about the increased risk of bleeding. If the lesion is distorted, then the patient might have pain, which we need to provide her good analgesics, and that should be provided to the woman in close liaison with the pain control and analgesia team. Otherwise, it is not an indication of cesarean section.
Any specific, you have already mentioned the postpartum plan, but anything else you want to add on to?
The woman should be counseled about the definitive treatment and appropriate follow-up, as that is very, very important in this case. So lower genital tract assessment for the status of the cervical disease, which was previously treated, and vulva and vagina should be examined, and she should be advised of adherence to the long-term follow-up for her HIV status, for her vulval disease, if it is treated, and also for her cervical disease follow-up. That is very important. So all these three aspects, they should be kept in mind. And before embarking on next pregnancy, she should receive pre-pregnancy clinic and preconceptional clinic, so that until and unless her situation is optimized, then she should embark on future pregnancy. Until then, she should be connected with contraception clinic, so that she can have good spacing in the pregnancies.
Okay, so like how would you counsel this patient? Because I think VN3 is something which people would be always worried of. So what are the specific counseling points you would always consider?
So in this disease, first of all, the woman should be reassured that this is a pre-malignant condition and this is not a cancer. However, proper follow-up and proper treatment of the disease is very, very important. The other important thing, she should be counseled that pregnancy hormones and her HIV status. Pregnancy is also one factor which is reducing her immunity, and also HIV. So there can be persistence of the disease, and there can be problem with the recovery phase. So she should be counseled about that. this disease is not going to alter the fetal outcome. However, it should be treated, definitive treatment should be done in the postpartum period, and also she has to adhere to the HIV, as this, if the viral load is uncontrolled or it is very high, that can affect the baby as well. The baby may need in the postpartum period antiretroviral therapy, so appropriate follow-up for that is also very important. And also cervical disease needs long-term follow-up, so she should stay compliant with the long-term follow-ups, and she should plan future pregnancies very carefully. And also, as she is at the moment, she is combating three problems: her previous cervical disease being treated, she is having HIV, also this vulval problem, so this can affect her mental health, so she can be connected with the counseling services, or psychological support is also very important. And also, if support groups are available, she should be connected with them, so that her mental health is reassured.
Okay, so thank you. I think you have covered all the questions. Thank you.
Thank you so much. Thank you.
Yeah, Tazeen, I thought it was a very descriptive one. So probably you have covered everything in depth. So only thing is probably a bit about the time management, because we have added extra questions, I think. So that is the only thing. Otherwise, I think, and during the management, probably both VN and HIV, if you could cover as a candidate, the time would be saved. Otherwise, I think you have covered almost every single thing about VN3. Well done. Thank you.
Thank you so much, Dr. Soumya. Thank you so much. So we shall now go through the task, which is also exam tested task. However, there can be changes, and you should be aware that if vaginal intraepithelial neoplasia with other risk factors is coming up in the exam, how you have to cover. So here, this is a patient who is 26 weeks pregnant. She is having vulval intraepithelial neoplasia. She is also HIV positive, and past history of cervical intraepithelial neoplasia is also there. So these can be potential examiner's question. Summarization of case is always a first question in the exam. So you should be very structured about the summarization of case. Additional information includes information gathering from the patient, and always information gathering is to collect the risk factors. What other risk factors can be there which can affect the disease progress, which can affect the disease recovery, and all examination findings. What various differentials, if the diagnosis is not coming given, then various differentials should be in your mind, that how you have to take the disease in a broader aspect to manage this patient. How this vaginal intraepithelial neoplasia can be treated in pregnancy when the patient is pregnant and she is 26 weeks pregnant. About the management of HIV, how it can affect this, what would be the mode of delivery, what would be the postpartum plan, and how about the counseling of the patient. So summarization is 26 weeks pregnant with high grade vaginal intraepithelial neoplasia, also with a history of HIV infection and previous history of cervical intraepithelial neoplasia. So this is a patient who is high risk with multifocal lower genital tract disease, increased risk of persistence, progression, and recurrence, particularly due to immunosuppressive condition and pregnancy as well. In the additional information, we will inquire about her symptoms, duration, and progression. And then HIV history is very important. Which antiretroviral therapy she is using? What about compliance with the antiretroviral therapy? What about the recent viral loads? Her obstetric history, previous cervical intraepithelial neoplasia treatment, how it was treated? What about the follow-up? Her personal habits and smoking history is very important, as smoking is among one of the risk factors for the development of vaginal intraepithelial neoplasia as well as cervical disease. Sexual history, sexual partners, previous sexually shared infections, immunosuppression and co-infections, and psychological impact, as she is having multiple problems. So what about the mental health of the woman? Examination would be general examination about the general well-being, observations, careful vulval inspection with consent in presence of chaperone, to see the site of the lesion, size, color, multifocal focal lesion if it is there, ulceration to exclude the invasive disease, speculum examination to see the cervical status of the woman. And then during examination, we have to be very cautious, as there can be risk of bleeding on touch and discomfort can be there. Differentials can be vaginal intraepithelial neoplasia, A human papilloma virus related usual type, it can be vulval squamous cell carcinoma, condyloma acuminata, lichen sclerosis, vulval infections, or inflammatory dermatosis. Further investigations apart from vulval biopsy, we have to do HIV monitoring for viral load and CD4 count. We have to review the cervical cytology, colposcopy, and no routine imaging unless invasion is suspected. The management of this woman would be individualized and by a multidisciplinary team. It is a pre-malignant lesion, not a cancer, so the woman should be reassured with fetal-maternal implications. Conservative management during pregnancy if there is no evidence of invasion or if the lesion is stable and asymptomatic. This would be general hygiene measures and lifestyle advice, optimization of general health, careful surveillance with regular vulval review, deferring the definitive treatment until postpartum, symptom control with emollients and analgesics. If intervention is required, then we may need intervention if the symptoms are severe or if there is risk of invasion, and that should be limited local excision, and definitive treatment should be in the postpartum period. HIV can affect and it can increase the risk of multifocal disease, recurrence of the disease, progression of the disease. So, antiretroviral therapy adherence is very, very important, and multidisciplinary team in close liaison with the infectious disease and HIV team should be there. And postpartum surveillance is also very important. Vaginal intraepithelial neoplasia is not an indication of cesarean section. Vaginal delivery is acceptable unless large obstructive lesion is there, severe pain is there, risk of bleeding is there. Cesarean section decision should be obstetric and not based upon the vaginal intraepithelial lesion. The definitive treatment in the postpartum period would be surgical excision or laser ablation can be there. Further assessment of the lower genital tract, including vulva, vagina, and cervix, should be carried out, and long-term follow-up should be advised for HIV for her previous cervical intraepithelial neoplasia, which was treated. High risk of recurrence. If there is any social habits which needs to be optimized, so she should be connected with the stop smoking services, and she should be advised for long-term follow-up for her cervical disease as well. This patient should be counseled in a very sensitive way about vaginal intraepithelial neoplasia, which is a pre-malignant lesion and not a cancer. But it has high grade, it is a high grade pre-cancer lesion. So treatment as well as follow-up is very important. She should be counseled about the treatment and follow-up for HIV. She should also be counseled for the follow-up of her cervical pathology. Risk of progression during pregnancy is low. Treatment can safely be delayed until postpartum period, but she should be counseled about the importance of follow-up and postpartum treatments. She should be reassured that there are no concerns which can be associated with baby's safety or fetal safety. And she should also be offered psychological support, keeping in view the various risk factors which are there, which can affect her mental health as well. So I hope this task will help you in your exam preparation. Go through all the YouTube series which are designed for you. Subscribe the YouTube channel of Study Medic and stay updated with YouTube series. And once again, thank you so much, Dr. Soumya.
Thank you, Tazeen. Thank you so much. As always, fantastic. Thank you.
Thank you so much. Thank you. Take care.